a good personality and is always talkative and being with him is a pleasure.
Hello, good morning everyone. I am proud to introduce my beloved friend Mr. Badyal. He is also a Indian professor in our same college. He studied old Siddharth Medical College, that is private one at Vijayawada, and JJ Medical College Dharmagere MSc. When he told the fun fact is, a patient was first seen by ENT surgeon focusing a bullseye lamp light over his face. He shouted at it, "How can I open my mouth if you focus a light on my eyes?" Like that. Okay, sir. Thank you.
I'm introducing Dr. Chaitanya sir. He is currently working as assistant professor in Department of Pediatrics and also in charge of NICU and MICU. He is trained in UK and worked in various NICU and MICU over there. And he has previous experience in standardizing patients while he is doing his undergraduate and post-graduation. And one fun fact about the sir is like sometimes sir used to go to the office hospital late and he used to forget something in that day only. He has to go back to the home and pick up that thing and he will be more late.
Good morning everyone. It's my pleasure to introduce Dr. Devi. She is currently working as an assistant professor in Department of ENT here at ASRAM. She has some experience of standardized patients during her post-graduation and undergraduation while being trained in Vishakhapatnam. Fun fact about her is that she said that she can laugh even in bad situations. And the ma'am loves candid photography as well. Thank you.
Thank you so much. Thank you so much. I need to make have a rapport building with that population in that region. After that, you will be asking for recruitment, from advertisement and all, institutional level, department level. Suppose if we have made them aware, for example, slightly we know each other, know about each other. You also know across the table who are sitting people. So now if I ask, anybody wants to be a volunteer today to act as a simulated patient here? Okay, we have many. Okay, anyone from this side? You said you can talk to any cognition. Anyone? Okay. So see, that happens. After that, then we call these people. For example, let's count those who are raised hands. We are just depicting you that we have started with something which was sort of making awareness, and that in your culture it's very important to start that. As I told you, the first instance they started, community went against that. How you are teaching medical education. So that happens. After that, the second, people now you have focused on now. Now we will sit down here, come closer to that. Okay, so now will be happening this. These are the selected people who will act as simulated patient in our program of institution. We just assume we are an institution right now. That what are we are thinking about that. So those issues we will discuss them. They will have some questions. And we will also say some of the example you shared, like OSCE, teaching, seeing some patients who have behaved and how you reacted to that. When we talk of simulated patient program, we are talking about a normal person also. Sometimes they have some findings also. And rest of the things we teach them. We give a script also. Like an interview script was given to you, a script will be given, and there will be a brief also, as Dr. Nageshwar has done you, for the same script. And then they have to ask questions. We have modified few things here. We have put standardization. We have put country also. But nobody has asked the question because we started with simulated patients. So when these doubts are there in the instructions and the verbal things, you have to clarify these also. Okay, so then we sit down and we clarify. We are talking about simulated patients. You don't have symptom, but you have to act like that. Okay. Even some places, even India, we have very good, you can say, rich cultures in each state. You will get many actors. So those people are still there, those communities are there who do plays and other things. You get very good actors. In your own institution, you get very good students or other people who are. Okay. I'm starting with one example of OPC poisoning, which is common in Punjab. Earlier we used to teach pharmacology in a lecture. You might have also attended. Atropine is to be given, pralidoxin, OPC, you remove the clothes. And class of 250, a lecture is taken. Okay. When the question comes, you know answer how many of them right. Versus, you are doing this now with a simulated patient in a small groups of 25 or so. And we take one of them as a simulator carrier. You already aware of most of you. We are talking about a program. We will not depict full simulation here. We know you know initial part, breathing happens, then actual scenario happens, then there is a debriefing. That is the part of individual simulations. Remember, some of you talk about simulation, which might be computer simulation. We are not talking about that also. We are talking about a human here. So, can you have a mic? So we are depicting, we have reached this stage where we have one person. One actor has ready for acting as a organophosphorus poisoning patient, insecticides, pesticides. And I'm briefing the person and we are making normal conversations about that. So you will be acting like OPC patient, some farmer who was working in agriculture fields. 2-3 days you are doing sprays in the fields, but today you are feeling those type of symptoms like lacrimation, urination also. Now you are feeling drowsiness, in between unconscious. Two people that from your home has brought you to that type of thing you have to do. So you have to react in that manner, that you are drowsy or slightly unconscious. You are vomiting also. You will put some vomitous material here also, so that will be there. When we start the scenario, when you start, you are lying down on the bed. That part will start. And two people will make a lot of noise, your relatives and all. Doctors will try to ask you many questions, but you will be acting like you are not able to interpret everything. You are in a semi-conscious condition. Like you don't really where you are.
Okay.
Not where you are. Any questions? So you will be acting. There will be 5-6 students. Anything else you want to ask? You have the apprehension, you have to act like that in front of students. First 5 students will be playing role play. This is a batch of 25 and 20 will be sitting as observers. They will be observing you. We are also giving you a performer on which other people are observing checklist. While they are looking, while they are talking and all that. They have a checklist, we are giving you that also. You read it, go through that. Later on, if you think these 5 people have not acted like that, you can also actually tell them. Okay, that's what I was doing. Any question or you want to innovate on this? You want to add some local taste into that? Local language will be better. We will first ask all the 25 if they are able to understand the local language. The local language. Because we are getting students from all states. Anything else? Come to your mind. You want to reverse this? You have options, so you can do that also. You can go through all the papers, the checklist, have your questions again, we can discuss again, we can rehearse also, and then we do it. So that you, so maybe in a year we need only this 3-4 times, but in a week's time we need it. Is that all? Okay. What's your schedule? And your traveling and compensation fee of loss, that part we will be able to take care of. What questions you people have then when we are doing this? Something coming to your mind.
When a normal patient urinate and vomit, it becomes
for him to enact?
So what we do is, as I told him, that we have already a vomit prepared. It will be here on the sheet. For sweating and all, we use these hand sprays which come, sanitizers, that give you a same feeling that we will be using. So,
What I wanted to ask you, how much of scientific content you give to these standardized patients? You told him about the dramatic aspect, about the acting aspect. How much is the scientific content to the background?
so based on the literal level of literacy level of this person, you will ask this person, should I explain you? I also have the material which I asked, that we will give you all the papers. You can go through, sit down, again come with the questions. We will again discuss and even rehearse also before doing that. So you can give all the papers, depend on them whether they want to read everything or they want to ask you. Well, if I give them a full protocol of how to give atropine, maybe that is not relevant to them. But some of them want to read. Let them read also. So you can give them whatever questions they have, address them in another session, then rehearse, and then maybe after that they are ready.
But if the SP is illiterate and like they are giving, so like he won't be able to read out
Then I will not choose this person particularly which you have labeled for this exercise. We will use this person for some other procedure or something. Where much of the role of reading is not. Okay, no procedure, big procedures involved, something like that.
So is it that you give the scientific information only when analysis or without?
If a person is literate, then you give it. They want to read, they can go through it, ask more questions later on. But they don't want to read, they want to ask you only, that is also
Explanation.
as I told you, schedule of atropine paradoxin is not needed. But okay, the 2 drugs will be given by this. That is sufficient. That type of information.
Is it okay that the person is on act on it, doesn't want to take any scientific information, only acting?
Some people do that also. Somebody who's already acted as a simulated patient. Next time you call for another scenario, they pick up it very fast. First time it is difficult. Next time they will pick up. You might have seen some of the people you are calling for your exams. Next time you start, they will say, no, I know I will do this. You say them, no, stop first, listen, this is different. You tell them, stop, this is different. First listen to me and then you go. That happens. And so, especially if you are using some actors, they will ask you more details. They will ask you. Then they will even try to act out, rehearse and that, go through those things. Other people can jump into activities, but you will see that there are issues. They don't need to stop, tell them, okay, this can be that. Because here people are called, they have, inducement is not much, it will be only compensating for that components. People are paying, pay schedule is there. Most of the 4 or 5 institutions in India are already using this program. They have their pay schedules, which are based on the type of activity. Even examination has more money. And depending on where you are examining, that is also based on the money. Okay, so that part is here. So we tell people whenever we go that in your institution you have a lot of workforce. So in those people, for example, physiology people have a lot of technical staff which are already working as surgeons. Physiology people, when you do BP, your reading and all, usually you technicians from your department. Right? And OPC poisoning, we are also using some technicians, we have taken that per session. That's what we have built up.
Do you usually allow simulated patients to innovative or stick to your protocol?
Stick to your protocol. If they have to innovative, that is during the part rehearsal. Where you are able to first observe that and you finalize, okay, this is okay, we can go ahead. Because here, especially the relatives which we pick up, they have to create a lot of ruckus at that time. If on that day, our competency is that how these 5 students, they are able to manage the relatives of the patient, then that becomes the more focus. You have to choose, we are coming to that also, how you will, that's the normal process how you use for a particular day, which stimulation aligning with the objectives. I wanted to go more on programs, how you run the programs. Money part will come in. That's what you can decide in the committees and all. All of you have essential skill labs now, your coordinators and others. You can make a schedule. Some schedules are available on, you can see examples of that also. Better is to have a guide, sort of guide, script for these people. That takes time to build up. Some scripts are available online also. Script for each things and the procedure which can be simulated. You make a list of that, see how many actors or simulated patients you need. Start creating script or get it from others who have already done. In India we have 800 medical colleges. If we just make one script for these patients, we can have 800 in a year. But we are not doing that right now. That is something we can do. Some of the students are also there. You might have some experience with the OSCE and others. What are your views till now? Because we are talking about a simulated patient programs where you have a lot of people available. You have a list of them, you know when to call for what purpose call. You have other things available. They have been trained to some part. You can have a workshop of them together. Workshop of them together. Once you have identified that, a batch, have a workshop with them together. Or some common features which will look at. Thank you so much. We will continue further. So remember, sometimes when you show them scenarios, there are apprehensions. Before they will agree to that, when you say you have to lie down, there will be a vomitous matter here and all those things. We take another scenario, for example, if it is only a simulated patient for teaching them administration of informed consent, which all of us are doing for various purposes. It can be for a procedure or a surgery or even for a research thing. Administration of informed consent for the thesis also, which you have done, which you have worked at and all of that. They are already made, scenarios are available, scripts are available for informed consent, teaching, learning and assessment. Two components are we are talking about. Simulated patient you can use on one day, maybe I can use him for this teaching learning session, which I told you was teaching learning session. OPC poisoning in second year in pharmacology. So feedback which we got from students is, sir, now we can write on this anytime, anywhere. We give them students get sheets which has a protocol also, the scheduling of the drugs and everything. So that part we have built into that. I'm not going into those details which are part of simulation-based teaching. That depends on which scenario you are using. If you are using suturing in the surgery and before initial interactions which are there with the patients, those can be part of simulated patients. Before the actual switching what happens, those components can be there. Surgical procedure, lot of consent forms are needed there also. Ultimately what happens, somebody will tell you sign here without going through that. But these days people are asking for where I am signing. They ask for that. And because of CBME, the change which we have seen now, especially from simulated patients, the students you have trained 2019 batch, which have already into market now. The product is already into the market. So what we have observed the last few months, during internship and after that, these students, when they start their conversation, they say, my name is this, what is your name? This is the way they are starting. And earlier batches who are looking at these patients, they say, what you are doing? Because they are not even asking me. So with the CBME, the importance of simulated patient has become more. Because we are teaching them like that. Skill labs started at that time, which are full-fledged now in most of the places. Funding was not an issue. Some funds now of the skill lab budget you have to put into, divert right in the beginning to creating programs, simulated patient programs. Because funding is needed. People will come. You know all this works in India, other countries also. For these actors and all, the funding is needed. You need to follow that. If you look at versus using patient and also in the long term, you will find this is cost effective. When you use it. Because you can use multiple times in the teaching learning. And later on when there is a final exam, let's talk of pharmacology. In the OSP, this part will be. One part of this we will take to OSP, which they can handle in 3 to 5 minutes. Maybe only investigating drug in the OPC patient, something like that. So one part, everything you can't take into that. In the postgraduate exam, you can take bigger also, where you have more time, 15 minutes or so. Undergraduate usually you have a time of 2 to 5 minutes per in the option. That your assessment how will use this program is according to that. But again you have to tell to the simulator patients when they are coming, how much time they will spend. All that has to be talked about. We will go to some technicalities now. So 250 of your batch going through the same sort of standardizations. Provide enhanced preparation for future healthcare, especially in your region, because we are looking at that they become first contact positions in the community. Recurring and maintaining a diverse SP pool, if you have made a pool of those patients, is essential to achieve learning objectives and cultural competence. We are talking about multicultures now. Remember that a free college, you have faculty from different states, you have students from different states. So when you introduce this also through your SPs, because they also act like culturally diverse patients, that is also vital to that. Implementing an extensive vetting process to hire and retain SP will ensure the delivery of a high quality learning experience. Once they are trained, you have a pool, you will find it's very easy. At least for next 4 or 5 years, the things are taken care of. You will reach higher level of standardization. Initially, it will need a lot of investment of your time and resources for training them also and align the process in your institution. Regular systemic evaluation of SP will contribute to improved SP performance. Obviously, when they come second time, another scenario, third time, learners' outcome also will improve and the programmatic success which happens with your program. As I told you, few institutions, only few institutions are in India, this is coming in the way. This SPs which you will create through the program in your institution or department, they can be used for teaching clinical skills. Everyone is using, mostly we are using for that purpose. Simulating a patient interaction, because communication now has become a very important component. In CBME curriculum, the 4th domain is communication. Most of the countries you will see they have 3 domains, but in India the 4th one is communication. So with interacting with the patients, that is there, a lot of simulation you will plan around that. And India people are very versatile in their communications. Okay, here the actors and all those people can be changed very well into that. Providing immediate feedback to learners, which happens through SPs, the immediately interaction is over, they provide feedback to that. You can video record this and send it to another third reviewer also, who will also see what is happening. Assessing learners on the clinical skills, not only teaching, we are talking about that. So what difference has been reported if you have an actual patient versus a simulator patients? Actual patient will give you history very fast. Actual patient will give you very correct, fast history. Simulator patient has been trained to put some interrupts into that, because he is challenging the learner. Okay, to modify your questions. When difficult patient comes out, you have to deal with that. So you will say that the actual patient of that disease will go quite fast. State will try to focus on that, and these days they are already searched a lot of things on the Google already before they come to you. So they want to have a focused talk. Simulated patients have been trained stepwise, how to go from one step to second step, the history, clinical examinations. So even if you forget something, they have been trained to give some prompts to the learners. They give some prompts to the learner. Do you think I should go to explain if the student has forgotten? Yes.
Since this could be misleading. Suppose if you are doing a formative assessment, so can we, is it very much reliable for a final exam? That's my question.
I am putting this question to the group. Sir has asked real patients, simulated patients, reliability. Important aspect. One of the 5 important aspects of assessment. Is it reliable or not? Anyone? Yes. One by one. We come to you, sir. Yes.
Sir, I think it depends upon the training of the SP, sir. First thing is training of the SP. whatever is the protocol you are following, and it depends upon how you are briefing it and providing a pre-briefing, and then post of it, the post-briefing part of it. So training part is most important, but can increase the reliability. I think.
One is training completely.
I think sometimes real patient is not reliable, sir. Because what will be information, but he is not bothered. Once the diagnosis and everything is over, and sometimes he is exhausted also. He's not very much interested in gaining the information. And sometimes he may
I'm coming to that. So we'll just take one by one training. Sometimes these reliability issues can be with the real patient also. Sir.
In the simulated patient in the university exam, we can use them in formative assessment, and whatever corrections are to be made or instructions are to be handed over, they should be handed over a clear-cut instruction of how to act or enact and what to say, rather than putting them directly in the university.
Okay, sir's question was, when we talk about reliability, I will break it to that. Can you rely on that or not? Reliability. Can you rely on that? There are multiple things on the day of final exam which we do. It's not only OSCE or real patient simulator. There is a long phase reliability. It is not that it is very high for all the components. Even other cases and all that. Even the examiners shifting so much. You are 4 examiners on that day. Okay. The way you approach a particular student here, another examiner is here. Even that issues are there. Reliability issues are there. How to decrease it, how to improve your reliabilities. One is proper training of the simulated patients. Proper training. Because what is happening is also true. Google patients who are coming to you, they have Googled everything, they don't want to go into details. They are very focused. The students complain these days. I was trying to ask, but he is not answering. We are training our students. On the other hand, I want to train that student in all aspects of history taking. Our simulated patient has been trained stepwise. How to give history, where to stop, where to give prompts. Learner will learn better versus a real patient who has Googled every information and he's in a hurry. He just wants, I'm worried with this or this. He doesn't want to go. That's also why I've seen there's no relation with the food and all. He will immediately tell you. Our students will not get that learning opportunities. So depending upon for what purpose we are using, one is if you are using for teaching learning, this is a very good model that can because it is going stepwise. Number 2, we come to the final exams. Now, final exam, real patient, the same thing will happen with the reliability with the actual patients also. Okay. But here still this person is trained. Observer have a checklist which are same with all the 4 examiners. One examiner going there, another which we have taken earlier example. Now they have a checklist which has been standardized, keeping in view the script of this simulated patient which you are given versus a real patient which might keep on changing because this real patient we have put up as a reality more. We assume this is very close to that, but we have not trained them as a simulated patients. So that issues can be there. Okay. So based on what is our purpose, teaching learning, assessment stakes are high or formative and for summative you told us already. Okay. And which type of procedure it is. If it is informed consent essential for all the postgraduates, I think we should be able to assess in the final exam also. There are other which are low stakes, maybe we can take the formative exam. So it will depend on which type of scenario we are talking about, then we can come. So I will come to sir first, yes.
I'd like to say something, sir. Science can be elicited on a real patient. Can they be elicited in the same way on a simulated patient?
I will show you some studies here, sir. Study stage, yes. They say the teaching learning for the learner to teach them all the steps, simulation patients are doing a lot of good jobs.
Like tenderness can be elicited on a real patient, but
we cannot simulate everything in the simulated patient. I will show you the list of some things. There are already a list which can be used for simulated patient. Everything cannot be simulated. We should not become heavily dependent on one method in teaching, learning or assessment. Use a mix of method One student I was talking to you in the lift right now who was with me from here. I asked him, he's from the 2020 batch. I asked him, you are a new curriculum. What are the issues or what things? He said, sir, everything is okay, but SDL is a problem. Student, if teachers give us material, teachers, that's better. Otherwise, we have to read that. So something what happens, we rely too much on one matter. Or lectures are good only, SDL is good only, that creates an issue. Here also same thing I am talking about. You have a mixture of that. You decide where you want to use simulator. You think standardness definitely we cannot do. Okay. So then you choose a real patient. So this is how you will align your choosing that competency for simulator patients. This is a good point actually. Okay. How you choose your competencies, which are fit for the simulations. Only then you use for them. Others you just think not possible. We will use something else. There are a lot of examples like what you have given. So that's very difficult to do in the patients. Sir.
Yeah, just complementing. Regarding this tenderness, now for undergraduate examination, we are having 250 students. Per day 25 students as per our university. So 10 days examination are there. And if 25 students keep on working on the same point, after 1 or 2 patients, the patient will become non-cooperative or become not cooperative. So then what to do?
So okay, so one thing is this issue, availability of clinical material, which we are trying to simulate. Now tenderness are of various varieties. So just a tenderness you want to show, people can simulate that also very well. Without swelling you want to show tenderness, maybe they can react like that. How well they are trained, that depends on that. If they are very well trained, it will become valid also, reliable also. 2 components of assessment which you are looking into also. Then it will work for them. Sir.
Just compliment what you have been adding, sir. It's a wonderful question, and the tenderness is a practical point. I think that training, the focus is on the ability, refining as much as possible, whereas the real patients, that will give another dimension of confidence. So, patients are not available when the student is ready and the class is ready perhaps all the time. Whereas simulated patient perhaps is available at the time of that material, everything is present. So, just like driving classes or even pilots, simulations, they give the ability and refinement. Definitely, of course, confidence will happen when we meet the real life scenarios. Both are complementary. And as I have been mentioning, how to make even the simulated client or patient to replicate much of the questions raised by the other members. So we are at a convergence. Ability is the focus. Confidence is of course based on the reality. It's a good question.
Thank you. Continuity with that only, what is written here, because this is very, very important. Providing feedback or simulating a patient interaction. After that decision is done, I was giving that example again, OPC patient. When we started using this, we were also fascinated by skill labs. We had a new mannequin which will cry, speak. We were fascinated by simulations. We used that in the OPC. We were not using a human there. And vomiters, everything was same. But students said, sir, this is mannequin only, we are not getting that feel. Right? This was very costly, expensive mannequin. We replaced it with a technician whom we are paying very less amount as compared to the mannequin cost which is here, which we will not be covering that. Now they said, sir, there is the actual realism. The patient shouts like that. We can see that he is drowsy and all, and that realism. So we are not, so computer simulations we are not talking about. Mannequin simulation right now we are not talking about. We are talking about how we are using humans for that. So that part is coming out, that aspect. Wherever you think that part will help you, there you use it. Okay, for example, I want to use IM injection, maybe I will use wearable patch, but use a human versus a artificial arm, which is there. You see IM, we are all teaching them, you might have seen the arms are everywhere in the skin. They are around 80,000, 85,000. There is a patch there. But you have already given a patch where to inject. Student is not doing anything. He is just injecting into a plastic. There is no realism. They are not palpating even. Where to? What we do is we put a human there. They do everything here. Ask the patient earlier injections, any state of energy, and they inject on the other arm where there is a wearable patch is available these days, which is very less expensive. Then students say, now we are getting it. Versus a arm on the table, which already has demarcated area. That is something we are talking about. I don't want to go into that aspect, stick to the programs. Yes, please.
I think wonderful discussion, but one small point you should really realize is that the feedback which is given to the students is much better if your SPs are really trained. For example, I think if you really look at most of these exams, the SPs will give a wonderful feedback to the students, especially. How did they really communicate? How did they really palpate? How did they really use the torch for transsimulation? I think that feedback, real practical, is missing in our day-to-day clinical teaching sometimes. And this is something which is, if you well-trained SP, I think the third point which you showed is most emphasized.
As you have run this scenario with the SP 3-4 times, after that, SPs are so used to prompts, they know student is doing wrong. In between, they try to give feedback. Then we stop them. No, only after that. They will tell them, we कैसे करो? Then we tell them, no, after that section, after scenario. So that type of, and students value this feedback a lot. For them, it is coming from a patient. Remember that learning is much acceptable to them. So when we talk of especially our scenario right now, IMG enhancing healthcare team outcomes, some of that you are told that asking. So this will improve patient safety. It is already reported in the literature. This is the biggest advantage reported. You become confident, you do multiple times, but on a simulated scenario, when you reach the actual patient to do that, you already have learned, made mistakes, corrected that, so safety improves. And they prepare them better for the future healthcare providers with no risk to real patients when you reach that stage. And this also provides students with a unique opportunity to respond to complex situations in the clinical environment. Because these SPs, as I told you, they are given prompt. They are also given, okay, sometimes in a complex situation, you can act like this or this. You have option 1 and 2 both, based on how the learner is reacting to that situation. Okay, so that, and you know, this earlier was done in the mannequins where you can change the parameters. But now you can do it in the humans also by training. Interprofessional simulation programs are needed, especially when we are talking about team building. That include SPs offer experiential learning opportunity to understand and improve the team dynamics, because all of us work throughout in our life on those small teams. And we have a lot of other people like paramedicals and other working with us. So that model, you involve that also. That gives us, simulator patients give us an opportunity to involve some other staff also, paramedical, nursing, in the training also. Some of them very good trainer. In one of the institutions where they are doing this program, some of the simulator patients have now become managers. They are recruiting other patients, they are training them. Their rapport building is much better than at the community level. Okay, so this program goes up to that level, then they can do this. So remember that we are talking about a peer assessment, as I told about on that tenderness and all. We have to devise, if we have a standardized things, this helps. Now I come to that question, many people ask, simulated patients or standardized patients? Are the same or different? They are different. They are different. Any other views? Simulated and standard. Then we will break for tea if you give a correct answer to that. Yes, sir. You want to say something?
It is under the umbrella of the standardized patient simulated.
Sorry, yes, sir. Okay, we listen to sir first.
Simulated patients come under the umbrella of the standardized patient.
Okay, they are come under umbrella of standardized
It's a
patient.
part of the standardized patient, but it is the little lesser acumen or little lesser.
Okay, sir. Sir.
I think simulated patient after proper training becomes standardized.
Okay, simulated patient becomes standardized when we properly train them. What else?
More consistency is there with standardized.
More consistency is there when we use the word standardization.
Related to realism, sir, how real it is or how close it to the patient, we can, on that basis, I think.
How
The
close?
degree of realism.
That is, you are saying for simulated or standardized?
Like the difference to say this is standardized and that is simulated, the realism comes the closeness to the real scenario is what is the aspect we need to see.
Okay. So how closer they are to that situation or scenario. Any other thing which comes to your mind? We are maybe open discussion. There's no, we are looking at right answer or wrong answer.
Standardized program, then
So if it is more program and as you said, more standardized, where its utility will be more. Some of the 4 things we are talking about.
Sir, can I say that the simulated is more for practice, like a deliberate practice, repeated practice. Standardized can be used for all the 4 modalities which you have added.
We are very close to that. Simulated we use for teaching, learning. We can use for assessment also.
Technical aspect will be more covered in standardized compared to.
So when we want to have a final exams, sir were telling